It's always nice to follow Joanna because she kind of like says it all, doesn't she? Good morning, everyone. Really nice to have so many faces, familiar faces and new ones. So if I don't know you, please come and say hello during the break. So I'm Rachel McIlvenna. I'm the Smokefree NHS Strategic Manager and responsible for this agenda. Well, partly responsible for this agenda. We all are in the region. And I'm just going to be providing a really quick overview of what we've been doing so far and kind of some of our plans for the future. So Joanna has obviously started this around trying to make the case for mental health and smoking and why this is a really important agenda. And we've been talking about this for many years, but not much has happened. So it's great to have the opportunity to be in a room with people who obviously have identified that this is something that needs urgent action. So we know that among people who have got mental illness, there are increased rates of smoking and they experience severe harm as a result of that. We know that it's the most important modifiable risk factor. So Joanna has highlighted already around 10 to 20 years earlier, people with mental illness who smoke die. And, it's almost half of the population. So again, if you think about any other risk factor that was causing, fatality rates of one in two, you would be wanting to do something around that agenda. And I think also important to notice that people with mental illness are more likely to be heavier and more dependent smokers. So that means dependent smokers. And so that means essentially that we need to ensure that we have appropriate strategies to support them, because offering them just traditional support doesn't cut it. And this graph, which I always borrow from Ash, just sets the case. So we're on a trajectory in England and within the northeastern North Cumbria to get our smoking rates down to less than 5%. Perhaps by 2030, if we continue to work together, but maybe beyond that. But actually for this cohort, and it's a big cohort actually, they're about 20 years behind. And I think we just pause for a minute and just question whether that is acceptable, whether that is justice, whether that is equity, if we're not doing something to close and narrow that gap. So some of you would be familiar with the Core 20 plus 5, which is around reducing health inequalities, and there are 5 clinical areas where there's supposed to be targeted action to reduce smoking rates and reduce the gap in health inequalities. And of course, severe mental illness is one cohort. So this people with severe mental illness in our patch are dying, 10 to 20 years earlier. And in our patch, around 42% of people with severe mental illness smoke. So that's, again, I guess, unacceptable. So we can do a bit more than that. Joanna has already referred to this, and whenever we do slides like this, we like to show this because this brings into focus why we're doing this. We must always keep the person who's tobacco dependent at the center. And then if you layer that up with the fact that they might have comorbidities or have mental illness, we need to think about ensuring that our services, that our programs, that our interventions keep that person at the heart. And this is our regional vision. It links into some of you who work in local authority, your ADPH position statement on smokers, supporting smokers, ensuring that we are meeting their needs. And I guess you might be thinking, where are you in this circle? This is our regional vision, so we are all playing a part. It could be that you're working in secondary care and that's your main role. That's great. You might be working in local authority, you might be working in a commissioned service, an in-house service, you might be working in pharmacy, or you might be in the voluntary sector. Everyone has an opportunity, and we need to make sure that smokers are directed to the support that works for them. For some people, it would be, specialist support. Some would need an additional layer of self-help, digital help. Some might need that group support, but making sure that we keep that smoker and that person with tobacco dependency at the heart of all that we do. So within the region, we've been working now very, very focused for a number of years on trying to ensure that we maximize the opportunities the NHS has. So the long-term plan, 2019 long-term plan, kind of set the tone really in terms of where our areas of focus should be. And in the first few years, we have focused predominantly around the secondary care space, those who are admitted into hospital. But there's been an opportunity to start thinking about the broader range of people who are not being admitted into hospital but are in contact with the NHS, whether they're in primary care, whether they're coming from outpatient appointments, and looking at what we could do. And then this cohort, so adults with severe mental illness now, who many of them are actually known to our services. They're on our GP registers. They are working with community mental health teams. We know where they are, but the support hasn't been provided in the past. So in the last 2 years or so, our work within the task force has been to cover a number of these work streams. So the second one, targeted work in primary care focused on severe mental illness. So again, the priority there, and I'll talk a little bit more around what we've been doing in the last few years around that. We've got CNTW and our four pilot sites who have been involved in the work. And there's an opportunity, I guess, for us to start thinking about our other mental health trusts and what we can do, and of course, evaluation as well. So I'm not going to steal the thunder of all the people who are delivering later on, and we've got 3 of the 4 early implementer sites who are here. So, you know, I'm hoping that you get to hear at least 1 or 2 of them. So we have, we had the opportunity to receive some funding from NHS England to be part of the early implementer sites, and there were 7 in the country. So the North East Cumbria was one of them, to trial out. And at that time, they said stress test a number of models. So we opted for the primary care model, and the idea was that when people were identified as their physical health check, then they would be referred to the appropriate service. So we, through a process of, you know, supporting and working with teams across the region, there were 4 pilot sites that were identified: Northumberland, South Tyneside, Middlesbrough, and Durham, particularly the Chester-Lee Street area. And they are denoted in the yellow stars. And I just wanted to put that there so you can kind of see the spread. And one of our aims from following on from this is actually would like to see the stars everywhere. Wouldn't it be great if every area had that opportunity for anybody who fits that category to be supported in a great way? And then the red spots are the spots for CNTW, which is our community mental health model. And initially started in the Cumbria area, but now we started in the Newcastle and North Tyneside area. And all the services have got similar approaches. So, you know, access to quitting aids or cessation aids, whether they be vapes, pharmacotherapy, flexible support, the absence of that tobacco, absence of abrupt quit, and that. But you're going to hear a little bit more about that. And I did say I was not going to steal their thunder, but it's been really useful because I think one theme that's come out of all the work has been the importance of that no wrong door approach. So rather than it being fixed to a primary care model and that's the only way we receive referrals, all the sites have been able to be really flexible. We've also had the opportunity to have an evaluation which is underway, will be finishing in March, and some of the team are here today, and this slide just summarizes kind of like the key objectives, because it's really important to demonstrate impact wherever possible. So last year, March, we had a celebration event, and some of you may see your faces. I see Carol's already smiling, so see if you can spot yourself there. And that was really just an opportunity to celebrate the great work that happened, given how difficult it was to even start up. And there was loads of learning that came as a result of that. And some of the people fed back some system aspirations in terms of what they wanted to do. And in a way, that's why we're here, because we needed to continue to motivate people to think, well, actually, yes, you had a really lovely celebration event and you talked about wanting to use the learning, but actually nothing much has changed since then. And we don't want to be people who just talk about doing stuff, but actually not doing stuff. So again, this is an opportunity to actually say, okay, what tools do you need? What do you need to have put in place to be able to make this a reality, using the learning, communication, flexibility, and working with local partners. And this lovely infographic that Josie Brooke did for us, and we can send this again if you've not seen that, kind of captured some of the essence of the day. And I know that we're going to have similar themes today, but I don't really want this to be a talking shop. I want us to go back with key actions in our practice. I did have a slide the last time, and I actually haven't changed it. I ended my talk with this slide, and it's still the same, almost 12 months. And it's a challenge that I would like us to think about even as we're having our conversations and networking. Are we implementing effective cessation and harm reduction interventions in all our settings, whether it's community stop smoking services, in secondary care, in primary care? Are we using the evidence base that we already know is available? And are we supporting those who need the most, those with complex multiple needs, across the different settings? So that's a challenge for us. We cannot afford to leave those people behind, so we need to be doing more. Thank you.